everybody, welcome to the latest episode of MRM Highlight YouTube video. Today we have the paper for November 2019 editor's pick from Herz, a PhD student from Magnetic Resonance Center, Max Planck Institute for Biological Cybernetics from Germany. In this paper, Kai and his colleagues investigated a T1 role-based dynamic glucose-enhanced MRI and 3 Tesla, with special focus for methods development and earlier clinical experience in the human brain. Without further ado, let's first take a look at the audio slides from Herz. Then Kai and the senior author of this paper, Professor Moritz Zaiss, will join us for a quick Q&A to discuss the paper and the work.
Hi everybody, and welcome to this MRM Highlights video about our T1 row-based approach for dynamic glucose-enhanced imaging. In the next few minutes, I will shortly present the protocol we developed and present the results we obtained with that so far. It was shown previously that DGE is able to detect changes of glucose concentration after an injection. That works the following way. We acquire a saturated image at a specific frequency offset. We do that over time, and at some point we start to inject glucose. Then, wherever the glucose accumulates in the brain, we have a stronger CEST effect and therefore a lower water signal. And when we then subtract the images after the glucose injection from the baseline image, we get our positive DGE contrast. Now, the whole method therefore forms a potential marker for blood-brain barrier breakdown or maybe even tumor metabolism, and so far it was mainly shown at ultra-high field. However, it would be pretty convenient to also have the protocol on a clinical field strength so that we can run larger patient studies. And when we want to do that, we are facing several problems. First of all, the CEST effect size is much smaller compared to ultra-high field. As you can see here, it drops massively when we go from 9.4, for example, to 3T. Second, of course, the SNR is lower. And third, no matter if it's ultra-high field or not, we always have motion and B0 inhomogeneity-induced artifacts. So our goals in this study was to first of all increase the effect by choosing sophisticated saturation pulses. Then second, mitigate the artifacts, and after these two steps we wanted to see if we can detect DGE effects reliably. So from simulations we know we can get the maximum effect, which is approximately 0.5%, with a short and strong saturation phase at around 0.6 ppm. And with classical shaped pulses like Gaussian, for example, we get artifacts. Since we are labeling so close to the water resonant frequency, we introduce these oscillations. Therefore, we decided to go for adiabatic spin-lock pulses, as they have less direct water saturation since they restore the longitudinal magnetization after the locking pulse. And with our amplitude-matched spin-lock pulses we published recently, we can label close to the water resonance frequency without any artifacts, as you can see here in this image. And here's then the measured C spectrum at 3T, and you can see that at every frequency offset we can label without any problems. In the next few slides I will quickly go through the post-processing steps, and especially motion correction is very important here, since residual motion artifacts can introduce effects that are in the same size as we would expect our DGE signal. And to be able to do a retrospective motion correction we need a 3D sequence and also a stable kind of multimodal algorithm, as the glucose injection itself can change the contrast a bit. And we evaluated different packages, namely SPM, elastics, and AFNI, and ran a lot of different parameter combinations. And as you can see visually here, elastics is the winner of this test, and we decided to go for that one. In addition to just pure volume mismatch after motion, there's also a lot of other stuff that can generate a false contrast. For example, we can have an altered slab selection if the patient moves in Z direction. And to be able to correct for these effects, we decided to use the following repetitive measurement pattern at these specific frequency offsets. Now, why do we do that? When we look at the DGE contrast we would get when we would just use the image at 0.6 ppm, you can see a clear hypointensity on the left side, and also the histogram is very broad. So we decided to use an interleaved M0 scan, which means we acquire a normalization scan at -300 ppm before each group of saturated scans. And when we then use that to dynamically normalize the saturated images, we get an image like that. The hypointensity disappears, and the histogram is also much more narrow. Still, when we look at the B0 inhomogeneity map after that 10 minutes, you can see a clear correlation between image B and image D. Therefore, we used the other measurements at these frequency offsets to perform a dynamic B0 correction as shown by Vinchu et al. And then you can see in image C a flat contrast, and also the histogram is very narrow and looks like a normal distribution around 0. Before we move on to the results, just a quick overview about our protocol. So after a relaxation period, we apply our spin lock saturation, which is then followed by a 3D snapshot CEST readout. We do this for approximately 70 minutes at the frequency offsets I just mentioned, and after 3.5 minutes we start to inject the glucose. Then after the measurement we do the post-processing steps I just mentioned, and we calculate our DGE contrast at 0.6 ppm, where we just subtract the images after the glucose injection from the baseline images before. Here you can see the results obtained from a glioblastoma patient measurement. You can see that in an ROI that was drawn in the gadolinium enhanced region, a clear positive contrast. Maximum is approximately 0.4%, which is in good agreement with our simulations and occurs approximately 10 minutes after the injection. What you can also see is that the white matter is not really affected. When we register the DGE maps after the injection to the anatomical images, you can see a very heterogeneous pattern which partly matches with the gadolinium ring enhancement. And I also brought results from another patient we measured where we did not see any gadolinium enhancement, and we also did not obtain any significant positive DGE contrast. So in conclusion, by optimizing our saturation, our 3D readout and our post-processing steps, we were able to set up a robust DGE protocol at a clinical field strength for broader applications. The DGE maps we observed showed a unique and heterogeneous pattern, which was partly matching with the gadolinium enhancement regions. Still, the effect sizes are very small, and therefore a careful application and evaluation is necessary. Thank you very much for your attention.
So the first question I would like to always ask is, could you please tell us a little bit about yourself, your backgrounds, and about your overall research at your institute?
I'm a medical engineer actually, and I worked a lot on medical image processing, especially like segmentation and motion correction registration. And actually during my master thesis, I was working with some data from the 9.4T scanner here from Tübingen, and I got more interested in like how the sequences work, how the contrasts are generated, how MR physics in general. And then I met Moritz at the institute, and then the projects he offered were cool, and he was cool as well, so I joined my PhD. Now I'm in my 3rd year actually.
Great.
I'm Moritz, and so I'm a physicist by training, and did a lot of MR physics in Heidelberg at the German Cancer Research Center. And so for my second postdoc, I actually moved to Tübingen, to Klaus Scheffler's group, and the nice 9.4 Tesla scanner there. Well, they also have nice 3 Tesla scanners, and I'm mostly working on CEST imaging. That's what I did my PhD in, and mostly endogenous CEST, so proteins, metabolites. And then the work started to go towards this glucose CEST effect, which also this paper is about. And I was joining Tübingen actually, not only for the nice scanners, but because of a European project. So it's a Horizon 2020 project called GLINT. So it's about glucose CEST in neoplastic tumors. And the challenge was to bring this glucose CEST that was already shown at ultra high field and in animals, to bring it to a clinical field strength. And that's how I came to Tübingen and to Max Planck Institute, and where Kai joined my team, and where we created this article.
Could you give a little bit introduction about what is the T1 rho based dynamic glucose enhanced imaging, and how does this new T1 rho technique compared with the more popular gadolinium based perfusion images? Because people use the gadolinium based perfusion imaging to investigate the brain perfusion for quite a long. And this new technique has certain similarities, but what's the difference? What's the pros and cons of these technologies?
Well, I can maybe answer on that. So first of all, I would say the biggest similarity is maybe just the idea or the protocol of injecting an external contrast agent, right? So
yes.
gadolinium, you take an image, then you inject gadolinium and you take another image and you get a, well, you get a bright signal where gadolinium is. In glucose CEST, or T1 row based, so T1 row and CEST is very related. So we use these terms synonymously. So it's glucose CEST or T1 row based glucose enhanced image. The idea is still similar, that we inject glucose and try to measure differences. However, first of all, the effect is actually goes down. So when we have a glucose CEST, so we have a saturation transfer from glucose to water. That means the water signal will be a little bit smaller where there's more glucose. Yeah? So we will first of all measure smaller signals where there's more glucose content. At the same time, a huge difference and something we really don't know yet is exactly the question you ask: how does it compare to gadolinium? Yeah? So it seems that it's not just perfusion what we see in this glucose CEST or DGE, dynamic glucose enhanced image. It does not match 100% with the gadolinium uptake areas. What we saw until now is that if we have a blood-brain barrier breakdown, then we also see some glucose uptake. However, the spatial correlation was often different. Yeah? Sometimes the glucose showed more up in the necrotic areas and in some gadolinium-enhanced areas, but in others not. And to date, we don't know. So we know it's something different than perfusion, but we don't know what is now more interesting, right? In terms of the activity of the tumor, for example. We know there's also some correlation with pH. So the glucose signal or the CEST signal is higher when there's a lower pH. So until now, it's not clear how much is it glucose concentration, how much is it just perfusion, how much is it actually the tissue pH or the extracellular pH in this area. So yeah, in a way, the original idea, hey, we just use glucose as a gadolinium alternative. This is not the case yet, yeah, or this is maybe never the case because it will be a different signal, yeah. But yeah, in some concerns, it's matches, and now it has to be evaluated. Where is it beneficial? Where is it a more interesting signal, or is it maybe not interested at all? Yeah, is it just like a necrotic or like some parts of the tumor light up, but they are not interesting? But this can only be answered in larger studies. So we developed a method now and still improving it, but maybe in the future this method can be applied to many more patients, and then we can decide, hey, this was really always more interesting than gadolinium or not. Yeah?
You have a strong background of image analysis, reconstruction, and post-processing. So when you do this research to turn 7 Tesla technique into more like application in 3 Tesla clinical scanner, what will be the most important and challenging parts regarding the sequence development, image reconstruction, acquisition, or the post-processing? What part you feel is most challenging part and the most essential for your research at 3 Tesla?
So well, most challenging is like the things we cannot change. I mean, like the CEST effect is smaller, it's lower field strength, and also the SNR is lower at lower field strength. So the challenging part was to still get a reliable signal despite all these lower SNR and lower effects. And yeah, it's really like in terms of optimizing, I think what was most important was maximize the effect, like choosing the right saturation patterns, because that is really like what determines the exchange from the glucose to the water, and this is also the more effect you can create with your saturation pulses, the more you can measure. There it doesn't matter if it's like clinical field strength or ultra high field. And what is also very challenging is the motion correction. So from previous work, we saw that even when there's a only small shift, like a small volume mismatch, we can generate effects that are like in the same effect size in which we would expect our DGErr signal, our glucose test signal. And since we have a lower SNR, we also have larger voxels, and then we also have some partial volume effects. So I think the most difficult and crucial part here was really to perform a motion correction that was kind of exact.
I think there are just a lot of steps that require fine-tuning and optimization to bring down some phenomena that happen at more detectable at 7 Tesla into the low field strengths at 3 Tesla, the clinical scanners. And I think it's great that you have performed such great work to make it applicable and working at 3 Tesla. And my next question for Professor Zaiss is like, I know that you have been doing the CEST for quite a long time in your research period. How does this work fit in your broad research goals? What's your pursuit in your future research using this technique to further develop this technique or somehow apply this technique for some clinical applications?
In a way, with CEST, we open the imaging world, and especially at ultra high fields, but also at 3 Tesla, we open the imaging world to metabolic contrasts, right? What you normally only have in spectroscopy, we now have as an imaging contrast. Yeah? It's very challenging in CEST to really say, hey, this is specifically this molecule or this effect. But, like the larger goal is to have a metabolic MR, right? That we not only see morphologic changes, or we see like perfusional changes when like the tumor or the disease has progressed a lot. What we want to see is very early, something is wrong with the metabolism. So maybe we should start a therapy right now, or we should keep track of what's going on. So I dream of that we have 3D maps, not only of morphology or structure, but of glucose levels, of creatine levels, of protein content, a 3D pH map to then really have a strong metabolic profile of the tissue as a 3D map, and then can guide therapy response, but also early diagnosis and things like that. Yeah? To just bring MR to a molecular MRI technique. I still want to add, so this is a goal. Yeah? We're not there yet. Also in this article, we really tried to tone down that we tried our best to show that it does not work, So tried really hard to show that it does not work, and we did not succeed. So that's the message here, okay? So it's really a tiny effect, and there's still a lot of problems with artifacts. So we have to be very careful. And this is all we can say, that until now, we could not disprove that it's possible. And of course, the larger goal would be to make this really reliable happen. But I think to encourage further researchers, maybe they can follow us, but there needs to be more work done in increasing the CEST effect, in have even better SNR, higher resolution, and to make this really work at 3T.
Awesome, great. How about you, Kai? What's your future research lined up with this work?
Yeah, so
how could this work somehow align up with the current work that you are doing, or the future work that you want to pursue to do? And how could this work help you for your further research?
I mean, it's somehow the topic of my PhD thesis, right? I started when I started at this institute. I did not know so much about MR physics, so I started to write my own Bloch simulation equations and to get to know the stuff. And from that, I started with the spin lock pulses, and they somehow fit perfectly for this glucose test approach. So I took like from Bloch simulations to the glucose test. And yeah, now it's the topic of my PhD thesis. So the main goal would be to scan more patients, definitely, and also do a larger analysis, because right now, as Moritz just said, we have just too little data to have a strong hypothesis or something like that. So that would be the main goal for the last months.
Yeah, my last question will be some easy questions for you guys. Is what you do normally outside your lab? Because after ISMN deadline, everybody is exhausted. I know some people take off a couple weeks for just relax. How about you guys? What you do after ISMN outside the lab?
So I had a long holiday before the deadline, so that's over for this year. But yeah, so I used to play football for more than 20 years, but I switched to more bone-friendly sports now, like running. And besides that, Tübingen has very nice surroundings for hiking and stuff, so like forests and hills and stuff. So I really enjoy that.
Great. How about you, Dr. Zaiss?
Well,
outside the lab.
I'm building spin simulations. Look,
that's
what I do in my free time. So that's a real 3D spin simulator. You see? Yeah, you can also make an adiabatic spin lock here if you want. But
that would be a nice tool to demonstrate the real MR physics, right? For teaching and for
so you can show
physics.
This is a flip angle rotation in the lab frame actually. That looks beautiful. Yeah, and that keeps you pretty busy in your free time. So yeah, there's no free time for a professor, right?
Yeah. Got that. All right. Thank you very much for attending today's interview, and appreciate everything you have done for this paper, how to contribute to the overall MRM society to promote this excellent tool for potential clinical applications in the human body. And thank you very much for taking this interview.
Thank you.
Thank you very much.
Okay.